So far we've talked primarily about two outputs of the ocular response analyzer. One is the corneal hysteresis measurement, which is an indicator of the biomechanical properties of the cornea. And the other that we haven't really talked about, but is kind of implied, is the IOPG, which is the Goldman correlated intraocular pressure measurement, which is somewhat similar to the traditional IOP value output from a non-contact tonometer. But because of all the information that we're gathering and because of how this measurement process has enabled us to get a handle on these corneal properties, we can now calculate a couple of additional parameters. And two of those parameters we refer to as IOPcc and CRF. IOPcc is corneal compensated intraocular pressure, and CRF is corneal resistance factor. Let's talk for a few minutes about the derivation of those parameters and what they represent. These parameters came from looking at the relationship of these two pressure values and combining them in different ways. Remember early on we talked about the measurement signal and we talked about the inward applanation pressure and the outward applanation pressure that we refer to as P1 and P2. And recall, if you will, that the corneal hysteresis measurement is simply the raw difference between those, P1 minus P2. The Goldman correlated intraocular pressure measurement, IOPG, is the average of P1 and P2. But if you look at these phenomenon, these pressure measurements, P1 and P2, as individual pieces of information, what you'll find, what we found, is that they are affected by the cornea in different ways. If you look at this plot, you'll see here that the P1 value versus central corneal thickness, the P1 dots are represented in blue, there's a much stronger relationship between the P1, the inward applanation pressure value, and the thickness of the cornea than the P2 value. If you look at the P2 dots, which are in pink, you'll see that the relationship between that applanation pressure and central corneal thickness is actually quite weak. Here's another hint that these things are affected by the cornea in different ways. Remember, we talked about the fact that the hysteresis measurement is reduced following refractive surgery. But let's look at what happens to these individual data points, P1 and P2, rather than looking at hysteresis as a whole. And what you notice is that the P1 value drops by about 3 times more than the P2 value. Basically, what the data were leading us to understand is that P1 is significantly more influenced by corneal properties than P2. P2 is a more corneal independent parameter. So if we're going to develop an intraocular pressure measurement that is less dependent upon corneal properties, then we want to use P2 more. And so basically, due to the fact that this clinical data showed us that P1 and P2 respond differently in a different manner to various factors related to the cornea, we were able to develop a pressure calculation using an optimum combination of these two parameters that is less affected by these corneal properties. So the definition of IOPcc is an intraocular pressure measurement that is less affected by corneal properties than other methods of tonometry, such as Goldman. IOPcc was developed using pre- and post-LASIK data. We looked at the changes in these biomechanical properties and figured out a way to calculate a pressure measurement that still agrees with Goldman on average, but is less affected by these corneal properties. Maybe not very important to note, but the formula, the raw formula for IOPcc is P2 minus 0.43 P1. And you see what that's doing is it's overemphasizing the P2 parameter and de-emphasizing the P1 parameter because the P1 parameter is more affected by these corneal artifacts. So does it work? Well, here's your traditional Goldman correlated IOP measurement versus central corneal thickness. We've looked at this before, 184 normalized, and you can see that the thicker corneas tend to measure higher and the thinner corneas tend to measure lower. That's not good. That relationship shouldn't exist. We want to measure the pressure, not the cornea. When you look at that exact same population with IOPcc, you see that that line has become flat. In other words, the average pressure measurement in somebody with a 450 micron cornea is approximately the same as the average pressure measurement as a patient with a 650 micron cornea. So we've taken the cornea out of the equation. How about some more evidence? Let's look at some patients pre and post refractive surgery. You see in blue here, this is a preoperative refractive surgery population, and in red, after LASIK surgery, it appears that their measured intraocular pressure has gone down by about 3 to 4 millimeters of mercury. We didn't change the pressure in the eye. We only changed the cornea. IOPcc, as you can see here, stayed approximately the same pre and post refractive surgery, showing you that the IOPcc pressure measurement methodology understands the corneal properties and takes it out of the pressure measurement equation. Now, when you start looking at this in different pathologies, you see very interesting things. Here's IOPcc and IOPG in a population of normal tension glaucoma eyes. And remember, normal tension glaucoma patients are typically patients who have glaucoma, who are progressing in glaucoma, but generally measure normal or low on Goldman tonometry. And we pointed out early in the presentation that when you look at the hysteresis of these eyes, you see that they are, as a group, biomechanically weaker than normals, even biomechanically weaker than primary open-angle glaucoma eyes. When you look at the pressure measurements in these eyes, you see that there is an offset universally across the board in this population here of 24 NTG eyes. The IOPcc measurement is reading higher than the IOPG measurement all the way across the board, on average by about 2.5 millimeters of mercury, but sometimes as much as 7 millimeters of mercury. It's very important, especially in these NTG eyes, to be able to make an accurate pressure measurement. First of all, in order to hopefully diagnose these patients earlier, and second of all, in order to determine efficacy of treatment once you've put one of these patients on drugs or perform surgery. If the pressure isn't as low as you think it is because of corneal artifact, then you get a false sense of security that you're treating this patient properly. Now we'll talk for a few moments about corneal resistance factor. Corneal resistance factor is similar to corneal hysteresis, but mathematically slightly different, and it gives us a little bit different information about the cornea than corneal hysteresis. In general, the difference between the two is corneal hysteresis is predominated by the viscous damping characteristics of the cornea. And corneal resistance factor gives us a little bit more information about the elastic properties of the cornea. The formula for corneal hysteresis is P1 minus 0.7 P2. We'll show you how we developed that formula and what it means clinically, why corneal resistance factor is different from corneal hysteresis. Talked about material characteristics of the cornea. We talked about material characteristics of building materials like a beam. And even though I've stated that the thickness of the cornea is not an accurate representation of the cornea's biomechanical properties, something puzzled us in the early days, and that was that the corneal hysteresis measurement, its relationship to the thickness of the cornea was very weak. You might expect it to be a little bit stronger than what it is. When you talk about isotropic building materials such as a steel beam, the strength of the beam is proportional to the cube of its thickness. That means that the thicker the beam becomes, the stronger the beam becomes. And when we looked at the relationship between the corneal hysteresis and the corneal thickness, we were a little bit puzzled by how weak that correlation was even in normal corneas. And if you look at this plot right here, you'll see that the pink line represents a normal population, and what we're looking at here is the correlation coefficient between the thickness of the cornea and the corneal hysteresis measurement value. And if you look at we're going to put a constant on this formula, so this is going to be P1 minus P2, which is the corneal hysteresis measurement, times some constant. So we're going to vary the amount of P2 in this equation like we do with the IOPcc algorithm to try and learn different things about the cornea. if you look at the pink line, you see that at a constant of 1, so therefore you're only looking at P1 minus P2, you have a correlation coefficient of about 0.19, representing the strength of the relationship between corneal thickness and corneal hysteresis. If you start to vary the amount of P2 in the equation, the relationship, the correlation coefficient between the thickness of the cornea and its biomechanical properties as measured by the ORA changes. So looking at the value of 1, if we start to increase the amount of P2 in that formula, P1 minus P2 times constant of 1.1 times a constant of 1.2 times a constant of 1.3, you see that the relationship gets weaker. If you start to decrease the amount of P2 in that formula, P1 minus P2 times 0.8 times 0.7, you'll see that the relationship, the correlation coefficient between thickness and this modified version of hysteresis maximizes at a value of 0.7, at a constant of 0.7. That's in a normal population represented here in pink. Now, interestingly enough, this behavior repeats itself in independent populations that are completely unrelated to our normal reference population. In the glaucomatous population represented here in blue, you'll see that that constant of 0.7 peaks that relationship exactly in the same place as it did with the normal population. When you look at another population of normals mixed with some ocular hypertensives who are not progressing in glaucoma, you also notice that that relationship withstands. The constant value of 0.7 describes the maximum correlation between the thickness of the cornea and the modified corneal hysteresis measurement. So what this means to us is that this formula P1 minus P2 times 0.7 is giving us some meaningful and repeatable information because it occurs in multiple populations and behaves in the same manner.